Acute coronary syndrome treatments. The treatment for unstable angina, a non-STEMI, and STEMI should all be the same in your brain except for percutaneous coronary intervention, something that you reserve for ST elevation MIs. In both situations, unstable angina, non-STEMI, or ST elevation MI, you need to prevent further platelet aggregation with aspirin and an anti-ADP receptor such as clopidogrel. We need to prevent more coagulation with heparin. We need to decrease myocardial oxygen demand with a beta blocker. And we also need to decrease preload and how much vasoconstriction is going on by giving an ACE inhibitor. Statins are also going to decrease the amount of available cholesterol that can further accumulate in the vessels. All of these help decrease mortality. Very high yield is that nitroglycerin and morphine are only for symptomatic relief. They do not improve mortality. All these other agents do though. They decrease the mortality. Now to cardiomyopathies, starting with dilated. So there are two situations that lead to dilated cardiomyopathy. We can have something that is intrinsic to the myocardium occurring, or a systemic disease that involves the heart. The easy way to think about dilated cardiomyopathy is there is some sort of damage to myocytes that leads to a decrease in systolic function. If you can't pump blood out of the chambers, there's going to be a significant increase in wall tension. The heart is going to respond by adding sarcomeres in series. What does this do? This is going to increase the wall thickness. This alleviates this tension, and it allows for the volume in the chamber to increase because sarcomeres in series can stretch. This is why hearts of dilated cardiomyopathy are usually 2 to 3 times larger than normal hearts. Do you see here how this ventricular chamber has a very large radius, and it also has a thicker wall? So we need to know the causes, so when our patient comes in, we can tell them what happened to their heart. Most of the time, we have no idea why. We call that idiopathic, or we usually think it's something that runs in the family, so a family history. Let's focus on what we do know. Alcohol and wet beriberi both deprive the myocytes mitochondria of vitamin B1 thiamine. We know this is crucial as a cofactor in the function of pyruvate dehydrogenase. Without thiamine or B1, you cannot make sufficient enough ATP because pyruvate dehydrogenase is not functioning. Without enough ATP to keep the myocytes contracting, we can get systolic dysfunction. In addition, acetaldehyde, which is this molecule here, the breakdown product of ethanol, is directly toxic to the mitochondria. It disrupts the connection of cytochrome C to the inner mitochondrial membrane. Do you remember from the pathology section what cytochrome C does? Well, when it is liberated into the cytoplasm, it leads to the activation of caspases. When you activate caspases, you get apoptosis. What are some other things that can lead to dilated cardiomyopathy? How about Coxsackie B virus? It directly invades myocytes, triggers an autoimmune attack on the myocytes because the immune system sees that they're infected by a virus. Trypanosoma cruzi, seen in Chagas disease, releases a very potent neurotoxin, and this can directly damage the specialized conduction myofibrils in the heart. Now, cocaine, doxorubicin, and hemochromatosis all result in chemically induced toxicity directly to myocytes. Now, cocaine damages the mitochondrial membrane within the myocytes. Now, doxorubicin is an intercalating agent. It directly intercalates DNA of the cardiomyocytes. Now, the excessive iron deposition that occurs in hemochromatosis leads to the generation of intramyocyte reactive oxygen species. Remember the Fenton reaction. This leads to the production of things that are very bad, particularly hydroxyl radicals. What do these hydroxyl radicals do? Well, they go around pulling hydrogens from places where they shouldn't, such as DNA, phospholipids, and amino acids. When you steal hydrogens from these guys, they become dysfunctional. Now, what about the dilated cardiomyopathy in pregnancy? This is due to a significant increase in plasma volume. So all of these lead to the eventual balloon-like dilation of the heart. You can really appreciate that here on this chest X-ray. Look at this radiograph. Don't let the pacemaker wires throw you off. You can really see the massive heart size. You will hear an S3 in this patient because the incoming blood will splash against an already large volume of blood that is sitting in the chamber because it is accumulating in the hypocontractile ventricle. The treatment for this should be to help these myocytes pump with digoxin. You need to decrease the preload with an ACE inhibitor. You need to tell the person to limit their sodium. Good luck with that. And you also need to give them furosemide to help alleviate some of the fluid overload. We also need to decrease oxygen demand with a beta blocker. If all of this fails, we need to take it up a notch, and we need to offer them an implantable cardioverter defibrillator, or ICD. The last step, if it gets really bad, is a heart transplant. Alright guys, now we move on to hypertrophic cardiomyopathy. Now this is going to show up on your exam. The vignette will usually describe a young athlete or a kid with Friedreich ataxia. Now 60 to 70% of the time, this is an autosomal dominant mutation in the beta-myosin heavy chain. This beta-myosin heavy chain is important for the contractility of myocytes. Now these patients have abnormal hearts starting at the level of the sarcomere. Instead of sarcomeres in parallel like this, due to the autosomal dominant mutation in the beta-myosin heavy chain, they have haphazardly arranged sarcomeres like this. There's also an inflammatory component which activates fibroblasts to deposit collagen amongst these disarrayed sarcomeres and myofibrils. These patients will compensate by adding sarcomeres in parallel to the best of their ability towards the center of the chamber. Now this will actually start to thicken the ventricle in a process we call concentric, or towards the middle of the circle, hypertrophy. Concentric hypertrophy leads to diastolic dysfunction because the ventricle is non-compliant. It will take a much higher pressure to fill the ventricle for any given volume. Now what's going to happen? These pressures are going to back up into the left atrium and into the lungs. That's where we get problems. We will see what effects this can have when we talk about heart failure in the coming slides. In a subset of patients with hypertrophic cardiomyopathy, we can see asymmetric hypertrophy of the subaortic interventricular septum. Why is this bad? Well, we obstruct the opening to the left ventricular outflow tract. This small aperture creates very high velocity, and this can actually suck in the anterior leaflet of the mitral valve and create a transient sudden outflow tract obstruction. Now, this sudden blockage of flow can lead to hypoperfusion of the brain, causing syncope and the sensation of dyspnea. Now, everyone has heard of that story of an athlete collapsing in the middle of the game, and the underlying problem was undiagnosed hypertrophic cardiomyopathy. Now, the chronic ischemia of the myocardium will eventually lead to electrical depolarization abnormalities. These patients will go into VFib and then die from sudden cardiac death. Be on the lookout for a description of any systolic ejection murmurs secondary to this subaortic interventricular septum hypertrophy. Now, what other findings should we be on the lookout for? We can really appreciate them here in this image. Check out the thickness of this ventricle. When blood hits this thick, very stiff left ventricular wall and diastole, it sounds like a fist hitting a wall. That makes your S4 heart sound. Sometimes you can have impaired mitral valve closure because the hypertrophy disrupts normal valve alignment. Be on the lookout for any descriptions of mitral valve murmurs in association with someone that has a history of syncopal episodes or family history. Now, let's talk treatment. We need to limit intense sports. We need them on a beta blocker to decrease the metabolic demands of the myocardium. Now, what about non-dihydropyridine calcium channel blocker? Why do we use that? Same concept. Verapamil is a calcium channel blocker. This decreases contractility just like the beta blocker. Decreased contractility means a decrease in myocardial oxygen demand. We sometimes need to give these patients an ICD if they are at high risk, such as previous episodes of syncope or a history of multiple myocardial infarctions. The name here should give you a rather strong hint of what is happening in this cardiomyopathy. There is some sort of infiltration of the myocardium that is going to restrict its ability to expand and receive adequate preload volume. So there's no problem with contractility, but the diastolic dysfunction is due to a poorly compliant ventricle secondary to some sort of infiltration that restricts the ventricle from expanding. Let's discuss the unique etiologies first, because those tend to be higher yield. The first one up is endocardial fibroelastosis. This name tells you exactly what the problem is. There's fibrosis and excessive deposition of elastic tissue within the endocardium. This appears in the first 2 years of life. Now, Loeffler syndrome is similar, except we take this situation of fibrosis and elastin deposition in the endocardium and we add eosinophils. They release major basic protein into the myocardium. Major basic protein is like dumping acid. It leads to necrosis and fibrotic tissue deposition. The fibrotic tissue is not very good at allowing expansion of the ventricle. Therefore, both of these diseases have a decreased ability of the ventricle to accept incoming blood. We talked about hemochromatosis, where there's a problem with iron. This iron produces reactive oxygen species. It particularly has a very damaging effect on the mitochondria of the myocytes. This can present as dilated or restrictive. Now, what about sarcoid and amyloid? Sarcoid and amyloid are both infiltrative processes. In amyloid, there is deposition and formation of beta-pleated sheets within the heart. The granulomatous inflammation in sarcoid can have many different cardiac manifestations. So the clue will probably be that the patient has other signs or symptoms of sarcoidosis. The last one is post-radiation fibrosis. This should be on your mind in a patient that has received radiotherapy for something such as breast cancer. Direct exposure of the heart to radiation is the reason that the heart will undergo fibrosis. All right, guys, another flash quiz. Just love these. What type of cardiomyopathy is associated with Friedreich ataxia? Hypertrophic cardiomyopathy. Remember, Friedreich ataxia is a trinucleotide CGG repeat in the frataxin gene. What is frataxin? Frataxin is a mitochondrial protein that protects against some of the potential harmful effects of iron. This protein is very high in the heart, the brain, and the pancreas.